Hello, good morning. Welcome to Mayo Clinic. My name is Elena Jelsing. I'm one of the non-operative physicians that practices up at Mayo Clinic Square in Minneapolis. And today we're going to focus on the foot and ankle exam. We'll start the physical examination by watching the patient ambulate. Obviously, based on the size of your exam room, it might be a short distance. If you need them to walk a longer distance, consider having them ambulate in the hall. So as we're watching them ambulate, we're looking for any signs of antalgia. Do they have an antalgic gait? Are they favoring one side versus another? We'll also be assessing their arches. Do they have high arches, which is called pes cavus, or do they have more flat feet, which is called pes planus? We can also look to see if they're potentially offloading a certain part of their foot. In this example, he's clearly offloading the medial aspect of his foot, concerning for pathology within the medial hindfoot, such as plantar fasciitis. Alternatively, they may try to offload the outside of their foot. In this case, we'd be concerned about potential lateral foot pathology, such as a base of the fifth metatarsal fracture or maybe a cuboid injury. Next, they may walk with a shortened stride. Oftentimes they're doing this to avoid terminal dorsiflexion, such as the toe-off phase of gait, because they have pain when they reach terminal dorsiflexion. This would indicate potentially an Achilles injury or retrocalcaneal bursopathy. Lastly, we'll ask them to walk on their heels and toes. So starting with the heels, if they have difficulty with this maneuver, it may be related to weakness, such as with a neurologic process, like a L4 or L5 radiculopathy or a perineal neuropathy. They may also just have heel pain, such as with a calcaneal stress injury or plantar fasciitis. So if they're struggling with the heel walking, you're going to want to ask them, is this challenging because of pain or potential weakness, to help you differentiate? Then we'll move to toe walking. Similarly, they may have difficulty with this from weakness, such as an S1 radiculopathy, or maybe an Achilles injury or a gastroc strain. Lastly, they might have pain in their forefoot, such as metatarsalgia, MTP joint pathology, or a Morton's neuroma. So next, I'll ask the patient to stand comfortably, shoulder width apart. We'll be evaluating their calf and ankles. So in this position, I'm oftentimes looking for asymmetry within the calf musculature, which again may fit with something like an S1 radiculopathy. Moving distally, we'll examine the Achilles tendon, looking for any focal areas of swelling or any focal areas of thickening, or even maybe some erythema that may indicate Achilles tendinopathy or retroachilles or retrocalcaneal bursopathy. In this position, we can also look for the too many toes sign. This is a test looking for a posterior tib dysfunction. In this case, if you look at his left foot, we see 3 toes lateral to his lateral malleolus. On the right, we only see 2 toes lateral to the malleolus. This is indicative of posterior tib dysfunction on the left. If we are concerned about the posterior tib, we can then ask the patient to rise up on their toes. If they went from that flat-footed position to maintaining their arch in this position, this indicates that the posterior tib tendon is in fact intact. Lastly, we'll ask the patient to hop. We'll start with both of their feet, so a double leg hop. You'd be asking if they have any tenderness or pain with that maneuver. If not, then we can move to a single leg hop on their affected side, again asking if they have any pain with this maneuver. If they did, that would indicate potential for stress injury. For the next part, we have the patient seated. One of the pearls with this is you're going to want to make sure that the exam height is appropriate. You don't want it too low so that you're having to examine all the way down here the whole time. You also don't want to have it too high so that you're providing a hamstring stretch for the patient throughout the exam. You want to start by inspecting the foot. So you'd be looking for any evidence of focal swelling, redness, potentially warmth, any deformities, such as bunions or bunionettes, or potentially hammer toes or claw toes. Next, we would move into examination of range of motion. And this is often performed as a combination of both active and passive range of motion. We'll first start by assessing dorsiflexion. And when you assess dorsiflexion, you want to assess it in two positions. So first, we'll assess it with the knee bent. This is really looking at soleus flexibility or mobility. So with the knee bent, you're going to want to passively dorsiflex the ankle. Now he has quite a bit of dorsiflexion. If you consider this 90 degrees to be neutral, he has a good 20 degrees past neutral. You'll then extend the knee and look at dorsiflexion. And this is a pretty good example. So again, if you use this as neutral, we can still dorsiflex him maybe 5, 10 degrees past, but not quite as much as we did with the knee bent position. Thus, this indicates gastroc Achilles tightness. When you're looking at this range of motion, you can ask them if they have any pain. If they endorse pain posteriorly, this often can be related to Achilles pathology, versus if they endorse pain anteriorly, this could be evidence of anterior ankle impingement, which would be common if they had some dorsal osteophytes on their talus or maybe some osteophytes on their tibia. You're impinging that might cause pain. Next, I'll move into inversion. So the best way to look for this is ask the patient to touch your hand. So with this, you can assess if they can actively invert, and then I'll say, can you please give me resistance? And so you'll provide resistance and see if they can hold that. So this is assessing for either pain or weakness with inversion, which would suggest potential posterior tib pathology. We can then do the same with eversion. So can you touch my hand out here? Good. And provide resistance. Excellent. So again, weakness or pain with this maneuver would suggest potential pathology to the peroneal tendons. Next, we can look at plantar flexion. So we're looking for range of motion with plantar flexion. We're also looking to see if they have any pain. If they have pain back here, this can oftentimes be related to posterior ankle impingement. So that might be the case if they had a large os trigonum. And then finally, I kind of round out our manual muscle testing by testing the strength distally. So this is looking at EHL strength, and then hold these toes strong. EDL strength. Can you curl your toe down? Good, hold that. FHL strength, and then curl these toes. Good. FDL strength. So we've done inspection, range of motion, and strength testing, and now we'll move on to palpation. It's most helpful to think of the ankle in kind of quadrants, so we'll break it up into anterior, posterior, medial, and lateral. And on the palpatory exam, it's often helpful if you ask the patient, can you point to where it hurts the most? Perfect. So if we start with the anterior ankle, you're going to want to palpate along the anterior joint line. And so we're moving kind of from a medial to lateral direction across the joint line. And obviously you'd be asking the patient if they have any pain as I'm pushing in that area. If they have pain across the anterior joint line, that might indicate a talar fracture, osteochondral injury of the talus, or interarticular pathology such as gout or osteoarthritis. You're also going to want to evaluate the extensor tendons that cross the anterior joint. So an easy way to kind of palpate the tendons is if you have the patient dorsiflex their ankle, that's going to bring out the anterior tib tendon. And so you're going to want to palpate along that tendon. Most of the pathology is going to be in the region of the extensor retinaculum, but be sure to follow it all the way down to its insertion. Then we'll move on to the EHL. So he was a very wise patient and extended his toe for us. And so we can follow that tendon down as well. And then most laterally is the EDL tendon. And again, multiple slips that you can follow for palpation. So that is the anterior palpatory exam. Let's move to medial. So if we continue our anterior joint line, it's going to extend into the medial gutter. So if they have pain in this region, it might be caused by one of the intra-articular pathologies that I previously mentioned. As we move around to the retromalleolar region, they might have tenderness within the tendons that cross this region. The most common is the posterior tib tendon, which is the one that's most close to the bone. So if they have tenderness directly behind the bone, think posterior tib tendon. And that runs distally to the level of the navicular. They may also have pain with palpation of the FHL or FDL tendons, but those are a little bit further posteriorly. You can do a Tenel's over the tarsal tunnel, and if they have irritation of their tibial nerve, that will send paresthesias to the bottom of their foot. Moving more distally, you want to palpate the navicular, which has a prominence along the medial aspect of the midfoot. That's a high-risk fracture, so you want to make sure that you palpate there. And if I move even more distal and a little bit plantar in this region, they may have pain here. This is the location where the FHL and the FDL tendons cross. And anywhere where you have tendons crossing, you can have friction that creates pain in this region. This is called the knot of Henry. They might also have irritation of the medial plantar nerve that runs adjacent to these tendons, and this would cause paresthesias in this distribution as well, and that's called jogger's foot. Next, if we go posteriorly, obviously you want to palpate the calf. So you have medial and lateral gastrocs. And then as we come down, this is going to form the Achilles tendon. When you're palpating the Achilles, you want to make sure that you palpate proximally, as well as intrasubstance, as well as distal, so the whole course. Most commonly, tendinopathy is going to occur at the intrasubstance region, and this is because the blood flow to this region is in this direction as well as this direction, and it forms a watershed area. So this is the most common spot to experience tendinopathy. You also want to palpate slightly anterior or deep to the Achilles. So if this is his Achilles, just a bit deep to it, as this is a region of the retrocalcaneal bursa. And so they might not have tenderness to palpation over the Achilles, but they have a little bit more tenderness deep. And then we'll move on to the lateral ankle. We can continue the palpation of the joint line. So this region is called the lateral gutter. Again, intra-articular pathology may present with tenderness in this region. It's also the region of the ATFL, and that is the ligament that is most commonly injured in an inversion type ankle sprain. In addition to tearing this ligament, as this heals, you can get hypertrophy of the ATFL and also hypertrophy of the synovium in this region. When this occurs, and then the patient is in a dorsiflexed and everted position, they pinch the tissue here, which is called lateral ankle impingement. Moving posteriorly, we'll cross the region of the CFL. The CFL is the next ligament most commonly injured, again, in an inversion ankle sprain. And most commonly, people think of this ligament as oriented straight, kind of up and down, but really it's oriented a little bit more posteriorly. They may have pain in this region. If we continue posteriorly, they may have tenderness to palpation over the PTFL, but more commonly, they have tenderness over the peroneal tendons. So peroneal muscles form the peroneal tendons as we get down to the retromalleolar region. And so pain directly posterior to the malleolus is indicative of peroneal tendinopathy, and you're going to want to follow those tendons down. They both run in this orientation until the longest dives deep underneath the foot, where brevis continues to the base of the fifth metatarsal. So you want to palpate that entire distance. All right, now we're going to move to palpation of the foot. We're going to start dorsally and we're going to start distally. So obviously if they had a concern with their toe, you'd want to palpate the DIP and PIP joints, but most of your pathology is going to land at the MTP joints. And so you're going to want to palpate this region. It's oftentimes difficult to determine if the patient's tenderness is exactly over the MTP joint or in the intermetatarsal space, but as best you can, you're going to keep your thumb, and I have my finger on the plantar aspect as well, over the MTP and ask, is your pain worse here? And then sliding it slightly, in this case laterally, off into the intermetatarsal space, or worse here. And they may not be able to differentiate, and you can even slide on to the next MTP joint, but if they can differentiate, that might help you determine if it's more MTP joint pathology or intermetatarsal space pathology. MTP joint pathology could be anything from synovitis, osteoarthritis, gout, but intermetatarsal space pathology would be more indicative of something like a Morton's neuroma or intermetatarsal bursitis. So after we palpate the MTP joint, we'll work our way up the metatarsals. And again, I'm using my thumb to follow that second metatarsal shaft. And as you're palpating up the metatarsal, you'd be asking the patient, is there any tenderness in this area? Oftentimes I'm trying to be very specific, so if they do say there's tenderness, I'll consider that point A, and as I move, we'll say that's point B, which is worse, and that will help me narrow down the focus of their pain. If they have tenderness to palpation along the metatarsal, I'm concerned about a stress injury. And one of the special tests to evaluate for metatarsal stress injury is called metatarsal squeeze. So you'll squeeze the metatarsals together and see if this also reproduces their pain. Continuing along the metatarsal as we move proximally, we're going to reach the TMT joints. And patients may have pain at these joints if they have degenerative changes in their midfoot. And so again, I'd be walking up second metatarsal, second TMT joint. You can move over to third, walk up the third so that you know you're over the third TMT joint, seeing if they have tenderness in those regions. Now you'll want to pay special attention as you're walking up the second metatarsal because this region is where the Lisfranc ligament lies. The Lisfranc ligament connects the second metatarsal to the medial cuneiform, and this ligament can oftentimes be injured in trauma, sports-related injuries. But we want to make sure that we don't miss it because it's often a surgical fix. So oftentimes if you're concerned about a fracture or a stress injury of the forefoot, midfoot, you're going to want to compare your findings to x-rays. Moving on to the plantar aspect of the foot, again, distal to proximal. Things that you want to make sure that you palpate are the sesamoids, so the little bones under the head of the first metatarsal. There's 2 sesamoid bones, and you want to make sure that you're palpating this region to make sure that there's no tenderness here. Another common pathology in the plantar forefoot is a plantar plate injury. And so oftentimes patients with a plantar plate injury are tender to palpation over the plantar aspect of the MTP joint. So they would be tender to palpation where my thumb is. They also have reproduction of their pain with passive extension of the great toe. Next, we'll move on to the plantar fascia. And the easiest way to palpate the plantar fascia is to kind of extend the forefoot, and that really makes the plantar fascia pop. And so my thumb is running along the plantar fascia, in which case I'm palpating and would ask the patient if they have any tenderness. Most commonly, the worst area of their tenderness is going to be at its origin over the medial calcaneal tubercle. So they're going to have pain in this region. If they have pain in this region, then of course we're also worried about calcaneal stress injury. So one of the other tests to evaluate for calcaneal stress injury is called the calcaneal squeeze. So you want to interlace your hands or clasp your hands with your palms over the medial and lateral side of the calcaneus and squeeze. And if they have pain with this maneuver, then that would be concerning for a calcaneal stress injury. So now we're going to move to a few special tests. We talked before about injury to the ATFL with inversion ankle sprains. So the test that looks at laxity related to that injury is called the anterior drawer test. So with the anterior drawer, you're going to want to stabilize the tibia with one hand, and then you cusp the hind foot with the other, and you're going to try to pull anteriorly that hind foot, sliding the talus on the tibia. So again, stabilizing with the tibial hand and translating with the hand that's cusping the hind foot. So you're looking for laxity with this, and of course you would compare it to the contralateral side. Some people have more laxity at baseline, so you want to make sure that you're assessing the laxity with this test compared to their, quote, normal ankle. With the second degree lateral ankle sprain, we talked about injury to the CFL. And one of the ways to evaluate the CFL is a Taylor tilt test. So you can cusp, again, kind of the inferior hind foot, and I would dorsiflex them a little to engage the talus and the ankle mortise, but you're going to shift that hind foot medial and laterally to stress that CFL. Now, again, this might cause pain with an injury to the CFL. It might also cause pain if they had pathology within the subtalar joint. So this is called a Taylor tilt test. Next, we'll want to look at a high ankle sprain. So a high ankle sprain occurs when you have injury to the AITFL, which is the ligament in this region. There's 2 ways to test for a high ankle sprain. The first is the external rotation stress test. So with this test, you'll bring the ankle into dorsiflexion, and then you'll externally rotate. Now, I'm not being subtle with this. I'm actually trying to do it as hard as I can. if a patient has a high ankle sprain, that will cause pain in this region. If they had a high ankle sprain and a concomitant syndesmotic injury, the force that started here travels up the syndesmosis and can actually cause a fracture of the proximal fibula. This is called a Mason-Hughes fracture. So if you're concerned about a high ankle sprain or syndesmotic injury, you're also going to want to palpate the fibula, and specifically, here's fibular head, specifically the proximal aspect of the fibula. Make sure that they don't have pain or potential fracture there. Lastly, there's a tibiofibular squeeze test where you place your palms over the fibula and over the tibia and you compress, so push together. The idea here being if you compress proximally, you're going to splay distally, stressing that AI-TFL as well. So that is a second test looking for a high ankle sprain. So our last special test is looking for a Morton's neuroma. As we talked about previously, if the patient had tenderness to palpation in that intermetatarsal space when you were palpating the MTP in intermetatarsal space, you might see suspicious for that Morton's neuroma. So this is called a Mulder's click. So in that space, so this is between the second and third in this example, assuming that that's where they were tender, you want to apply a plantar to dorsal pressure, and then you squeeze the metatarsal heads together while you're applying that pressure. The idea being that as those metatarsal heads come together, that neuroma is pinched and pops out between the metatarsal heads, and this creates a palpable clicking sensation. So if you palpate the click, that is a positive Mulder's click, indicative of potential Morton's neuroma. If you have a concern about a potential Achilles tendon injury, this is a special test called the Thompson test. So obviously the patient is prone, and you want to passively squeeze their calf. If the Achilles tendon is intact, you'll see what we're visualizing here, which is plantar flexion of his ankle. If the Achilles tendon was ruptured, when we squeeze, we do not see the plantar flexion. So this is an important test when evaluating for a complete Achilles tendon tear. Now, one of the things to keep in mind is that sometimes people can generate a little bit of plantar flexion, even with an acute Achilles tendon tear, because their plantaris tendon is attached. And so don't be fooled by a little bit of plantar flexion. Sometimes that plantaris tendon can give you a false negative. So to complete the physical exam, we'll do a small neurovascular assessment. When doing the vascular assessment, we want to palpate the tibial artery in the retromalleolar region, as well as the dorsal pedis pulse. This is most applicable when we're evaluating for popliteal artery entrapment. So popliteal artery entrapment is when the popliteal artery is occluded for one of multiple different reasons up back here, which causes a decrease in the tibial pulse with different ankle positions. So in order to evaluate, you'd find the pulse with the ankle in a neutral position, and then we would dorsiflex the ankle, assessing for any changes in the pulse, as well as plantar flexing the ankle, assessing for any changes in the pulse. A positive popliteal artery examination would be a decrease in the pulse with these changes of positions. From a neurologic perspective, we've talked already about looking for atrophy and weakness, but we could also look at reflexes. So when evaluating the Achilles reflex, we'll put them in a little bit of dorsiflexion, making sure that they are nice and relaxed. And we would check for an Achilles reflex. You can compare to the contralateral side if you have concerns that it might be too brisk or diminished. Next, there's two signs for upper motor neuron pathologies. One is called Babinski, and so this is where you rub a stick or the bottom of my reflex hammer on the bottom of the foot. I will often apologize beforehand because this tickles, but as you rub on the bottom of their foot, their natural reaction is that their toe will flex. If we did that and his toe extended, that would be a positive Babinski's, indicating an upper motor neuron issue. The second test is looking for ankle clonus. So if the ankle is relaxed and we quickly bring it up into dorsiflexion, you saw that he had one quick beat of plantar flexion, and that would be appropriate. 1 to 2 beats of clonus is normal. But if we did that and it continued to pulsate like that, that would be evidence of clonus, a secondary sign of an upper motor neuron issue. Again, my name is Elena Jelsing, one of the non-operative sports medicine providers up at Mayo Clinic Square. in this video addressed a comprehensive approach to the foot and ankle exam. Thank you for joining us.